Today, in the series of Docplexus KOL interviews, we have with us Dr. Jeremey Johnson, who is the Emeritus Consultant in Palliative Medicine and Director of Education and Research at Karunashraya, Bangalore Hospice Trust. Sir, welcome to the show.
Thank you. Nice to be here.
Sir, can you tell us about the relevance and importance of palliative care?
I may be somewhat biased, having worked in palliative care for the last 30 years, but to me, it runs through the whole of healthcare. It's not just palliative medicine, it's palliative care, which is actually about respect for people. It's about basic humanity. It's about how we actually interact with people. So it's part of every health worker's obligation in a way. But more specifically, I think people say palliative care and they think, it's only end-of-life care. It's only cancer. It's not. And I think the first thing to say is that palliative care, the term was only formed in the last 50, 60 years, which means to cloak. It comes from actually masking symptoms. But it's expanded way beyond that into healthcare generally, and it's about actually giving people quality of life. It's actually about not just focusing on curing people, but about caring people. And a lot of illnesses we see, particularly in India, are never going to be cured. So how we look after those people in their, horrible word, but the trajectory of their illness, it could be a few days, it could be weeks, it could be sometimes years. And how we look after them is absolutely critical, because it is about respect, it's about good interaction, it's about support for the patient and their family, because it affects families. And I'm talking serious illnesses. It started in the arena of cancer. That's where palliative care, mainly in the UK in the 1960s, in the hospice movement, was about patients with serious prognosis, usually life-limiting, where they would die. And that's where the concept came from. But I think over the years we've extended that. And certainly the recent Lancet Commission, which reported 6 months ago, looked at palliative care across the globe. It's a global view. Is that we're actually now looking at chronic illness as well as not just end-of-life illness. So people are living longer, particularly in India, across the world. The nature of dying has changed from acute illness, where people would have their heart attack or their kidney failure or whatever. And now they're actually living with those illnesses, particularly with modern technology, into considerably old age groups. And that's a challenge, particularly in rural areas where the support isn't going to be there. So for me, palliative care is part of everyone's job, but there are specialisms within that. So there's the generalist view of rural doctors, but there's also the specialist training for doctors who are interested in this work, who want to know more, who need to know about not just the medicines, and there are a few, but well used, can be highly, highly effective, particularly in the area of pain control, symptom control, but also knowing how to support patients around their emotional journey, how to sustain them in their psychosocial context. Because, for example, a young lady having a breast cancer, that's an easy example. She may have a young family. She may lose her job. Where's the money coming from? How's she going to cope? If she's worried about the dying process, who's going to look after the kids, their education? So it's not just about treating that lady in her pain or her cancer with chemotherapy or radiotherapy. It's actually about the wider context in which she's living and existing, and also the fears of the family. And sometimes patients find that side very difficult. So palliative care is not just about giving good pain control, although that's absolutely essential part of what we do, but it's actually about controlling other symptoms, nausea, vomiting, headaches, constipation, neuropathic pain, etc. And knowing about that is where we need the greater training for some groups of doctors who could then train other doctors. So there's challenges, certainly in India, but I'll just say once again, it's not just end of life, although that is a large part of what we do and doing it well. And also, it's not just cancer. So we've taken on, particularly in Bangalore, linking with the neurologists, with the nephrologists, about other organ failure like cardiac failure and respiratory failure, but teaching those doctors. Palliative care doctors can't do it all. There are comparatively few in India, maybe less than 100 highly qualified for the whole country. And in reality, in India, the challenge is only 3% of people in a country of 1.3 billion, sixth of the world's population, only 3% can actually access palliative care. And less than 2% actually have access to simple drug like morphine, which has huge impact on pain. So there's a lot of work to be done. I've been very impressed at this conference that there are a lot of youngsters getting interested, particularly in rural medicine, rural communities. And I think part of their training should be how to look after the patient in a holistic way, but specifically knowing how to apply good medicine to what they're seeing.
So my question is that it looks like when we're talking about palliative care, we are also focusing on empathy. And
Absolutely.
in India, the doctors often find themselves in a dilemma, like where to stop. So most want to be distant from the patient. How do you think doctors can balance it out?
The two are not mutually exclusive by any means. In fact, a good doctor will have empathy, they'll have compassion, they'll know how to talk to their patients, and a part of that is excellent communication. So when we're training doctors across the board, I mean, we've trained rural doctors from many states in India, and one of the things is actually about good communication. And if that is good, most other things follow. And some of the challenges around honesty, about patients saying they don't want to know, or more likely the relatives saying you shouldn't say. So there's issues around collusion. A good training in communication helps that compassionate, empathetic side, but also having these difficult discussions around futile treatments you know are not going to be of any use. And if I go back to the cancer example, there are a lot of third, fourth, fifth line chemotherapies on offer, most of which will have very little impact. They certainly won't change the mortality. At very best, they may, at the expense of great toxicity sometimes, by a few more weeks, at best. At best. So, embarking on futile treatments or taking somebody in their end stage disease, for example, to ICU, which is expensive. It's full of tubes and monitors and leads, and you distance yourself from the patient, and you're not actually giving them a better quality of life or death. And one of the challenges is having that discussion. And in fact, the recent Supreme Court decision in March about allowing talks around withdrawing and withholding treatments, that horrible, horrible term, passive euthanasia, it's not. It's actually about good discussions uh, in a clear manner about when to take away a treatment that is not going to be of any use, or withholding treatments that are going to be totally useless, and some of them very toxic. And that may actually extend to even simple things like overloading somebody with hydration. So that relatives may say, put a IV up, put a drip up, you must give them food, you must. A lot of patients who are so cachectic and so emaciated at the end of their life, to actually then suddenly overload the circulatory system has impact deleterious impact on the heart, the kidneys, etc. So just putting a drip up even has to be thought out carefully. So not doing it, i.e. withholding it, isn't necessarily wrong. And it gives doctors the chance to think out, and this is where we're very clear that patients should always doctors need to think about what they're doing with their patients. And the first, if you go back to Hippocratic Oath, the first thing is do no harm. And very often I see, sadly, particularly, and this is not a criticism, but in hospitals where money is very important, then in um, investigations that are not necessary, treatments that are not necessary, is what makes that hospital tick. So there's an unnecessary burden on the patient. And if they want to leave, they have to say, left against medical advice. And the financial burden to the family is awful. And the millions of people in India every year who go into impecunity because they run out of money trying to fund the last few days of somebody's life is actually totally out of proportion. So I think there is a morality within this. And I think the Indian Association of Palliative Care added to the WHO definition, I think it was 2014, what's socially acceptable and ethical to the definition. And I think that's highly important in a country like India, where so many people either can't access it, or when they can, they get charged a lot of money. Fortunately, I work in an organization where all the care is totally free. That's unusual. It's an NGO, it's unusual. Um, and, to give somebody a good death, a comfortable, dignified death with the people they want, and preferably in a place of their choosing. And certainly in rural India, that means home. So how we support them is critical to the well-being of the whole community and has an impact that runs all the way through society. And it is said that how you look after your dying is actually a reflection of your society. We spend a lot of time bringing children and babies into the world. We don't always spend the same energies and the same finances when people are leaving this world. And all of us are going to die. The mortality for human beings is still 100%. It's how you die that matters.
You talk about ethics in the medical field. Are there any checks that you can talk to us about that are there in other countries and that have been helpful in controlling these unethical practices?
Uh, I don't think there's two things really, and often the two get mixed up. There's, well, three things really. There's ethics, there's morality, and there's legality. Um, there's certainly a very clear code of ethics in medical practice, which basically is around autonomy, the patient's choice. It's about doing good, beneficence, and not doing any harm, maleficence. And the last one is justice. It's actually about social justice as much as. So if you've got limited resources, where do you put it? Do you put it into somebody who's not going to benefit as opposed to a population that is? So those are the four principles, and so long as doctors actually stick with those, they are universally accepted. Uh, until recently, I think it's been very difficult in India for doctors to withdraw from treatments because they always fear the law is not on their side. It may be morally and ethically correct, but they fear the litigation or being sued. So they hide behind making necessarily the right decision. It's catching up now. As I say, the Supreme Court at least is making a move in the right direction. That's come largely from the palliative care community, the IAPC, and a group called Elicit, which is the end of life care in India task force. There's a new national task force that's come out from, as you heard yesterday in the conference, as part of the national health missions, looking at various aspects. This is one. I think Palliative Care has driven that a little bit to saying, look, let's help the legal teams and the Supreme Court give us the right judgments, but I wish we could stand without fear. And the other thing is actually being clear about what we mean in our terms. So there's no such thing as passive euthanasia. The media love the term, the legal eagles like it, but it actually means nothing. Euthanasia is killing somebody, full stop. It's active, it's not passive. So, active euthanasia is killing somebody, is murder, it's totally illegal in India, and that should be perfectly clear. But passive euthanasia is actually about making the right decisions around withholding and withdrawing treatments. So I would just make a urge that we get rid of that term. Palliative care put a whole range of definitions forward, which has been accepted by the Indian Council for Medical Research, has been published again in the last couple of months, making what we're talking about absolutely crystal clear.
Right. And also, Dr. Johnson, you were talking about communication and empathy earlier. So I would like to go back to that. So should it not start at the college level itself,
Yes,
right?
yes, absolutely.
And also, should not palliative care be a part of
Yes.
each specialty, no matter what it is? A little bit, I think, should be integrated into the curriculum.
It's funny, earlier you asked about other countries, and I didn't directly answer that question because in those countries, things like the law, etc., are very clearly defined. Where education is concerned, in India, you're absolutely right. It should be right from medical school level, undergraduates. And the more enlightened colleges now are starting to take it on. We do some undergraduate work, but it's, a 1 hour lecture in the whole curriculum. Um, we're trying to get into more medical colleges. We'd like to see it as part of somebody's development, and certainly in the UK and other areas, medical students come to work in palliative care as part of their training, just like they would go into general practice or family uh, work with family doctors to understand the context in which they work. So we see this as really important right from the start. Because it should be running through, and not just doctors. When I say palliative care, it's about nurses, physiotherapists, counsellors, everyone working in healthcare should actually take those first basic principles with them. I'll say the specialism could come later, but the simple principles of palliative care, i.e., about quality of life, how to help people live well, should be part of everyone's think in working in healthcare, irrespective of where you are. Be the most sophisticated tertiary centre or out in the rural areas where the ASHA workers, the Ayush workers, the doctors and nurses working there should actually have the same principle. So you're right. Start right, plant the seed at nursing college, medical college, and other specialties, so they take that with them. But also for us to help them grow that concept. So we need to sustain it. There's no good planting a seed and not fertilizing it and watering it. It has to be sustained. So it's partly a culture change that we need to acknowledge this. And we're trying to get that into the undergraduate curriculum. And you heard I think it was the Vice President yesterday saying he wanted a medical college in every district. Great, ambition, but in what sort of doctors are we training? And if they don't have that element of compassion, empathy, and dignity, and respect for those, then they become technologists, as opposed, it's a technical medicine without that. It's a cold medicine, which to me is, there's a role for technology in medicine. Don't get me wrong, absolutely, and it's revolutionized medicine and life-saving treatments. But with it should come that warmth and that ability to interact with the patient. Because I think that is the essence of what good medicine and good healthcare is all about.
Do you think online communities like Docplexus can contribute to this cause?
Certainly, I think any sensitization and Docplexus. And I read the posts, some of which are more interesting than others. But in terms of sensitizing people, absolutely, because if a lot of people may not be aware of these aspects, it depends on the sort of training you have, the institution you work in, the pressures you work under. And I'm very aware that in India, whether you work both in the corporate sector, the government sector, or privately, there are always pressures: time, patience, money, targets. But those don't have to be at the expense of the basic humanity. And that's what I'd like to see fostered. And if Docplexus could do that, I'd be absolutely delighted. But in saying that, you are sensitizing doctors to maybe be a little bit introverted, to hold a mirror up to their souls and say, what sort of doctor am I? So if you could do that through Docplexus, fantastic. I'd be really happy.
Yeah, we definitely try our best. Before we conclude this, um, can you give a message to the medical community at Docplexus regarding palliative care?
Firstly, I would say is don't ignore it. Don't misunderstand it. A lot of people think, oh, it's a useless subject. There's no academic value to it. There is no, it's only about dying people. There's no money in it. All of which are wrong. Certainly, if you look at other countries, and I could talk about the UK because they would take postgrads, post MD level, and they have a 4-year training to become senior doctors and consultants in the specialty. Well, that's actually as a specialist. But we're actually training generalists as well. So it has a credibility in other countries, which it hasn't yet attained in India. Although palliative care in India has been around, well, we've just had the 25th, the Silver Jubilee Conference of Indian Association of Palliative Care, big international conference in Delhi in February. Fabulous event, but it's been in India 25 years, in fact longer, because it just started in 86, 87 in Shantiveni Ashram in Mumbai by Dr. Zita D'Souza as a concept. So it's been here, but what we haven't done is grown it. There's no career structure in palliative medicine or palliative care in India, and that's what we need to do. And in that sense, it hasn't got the respect from other professionals. And in educating, I always think of 4 Ps. It's our fellow professionals, number one, but also the public, the sensitization, and the politicians, but also our patients. So all of them need education, but certainly the doctors, because they do not look on back to medicine in the same way that you might view orthopedic surgery or nephrology or psychiatry as specialists, whereas it is. But it's a bridge between being a generalist and a specialist, and India needs good specialists to back up the generalists. So teaching fellow professionals, and if Doc Plexus could make people think about that, I'd be absolutely delighted.
This has been a great discussion. Thank you so much, Dr. Johnson.
Thank you very much, and thank you for the opportunity.